Welcome back to part number 2, or deux if you speak French, of the history of level funding. We're going to do a quick review and then we're going to move forward on how we got from where we started to where we are today. This is part 2 of 4. So we're going to cover the meat and potatoes of how we got from, and if you remember, the birth of employer paid and sponsored health plans and health insurance in the United States to where we are today. The model that we have, that we live under, live with, and are both proud and embarrassed by. So, to cover, in general, the modern American employer-sponsored health system started under FDR, when during World War II, they established the wage and price controls, which controlled what you could pay employees for their productive labor, but it did not stop employers from competing for high-level employees with employee benefits. This was now taken off the taxable income of these companies and allowed them to then recruit and give better benefits to employees to entice them to come over to work at my sawmill or my shipyard or my bullet manufacturer. After World War II, there was a little bit of a conversation around the Truman administration around whether we were going to nationalize or socialize or collectivize, whatever term that you identify with there, our entire medical system. And a group called the AMA, or the American Medical Association, and they came up with a thing called fee-for-service. Now, this fee-for-service is a deviation of a different model, which is fee-for-maintenance, right? So there's two ways to pay for healthcare. One is you pay for what you consume. The other is a subscription model where you pay as you go. It's like a gym, right? One is better for, in my opinion, better for the members long-term. The other is better for the doctors as it pays them for what they actually deliver. Now, there's some different trade-offs. There's nothing that's perfect in this world. It's all trade-offs. There's trade-offs in that system, and we went with the second, and the AMA signed off on going against the Truman administration's plan of socializing medicine and keeping it as an employer-sponsored benefit for the employees. All right, so after that, that's a little bit of a recap, maybe a little bit more deep. As you can tell, I love this subject. I've been reading books about it most of my life. So how do we pay for the care that is consumed based on the fee-for-service model? Well, we pay for it based on collectivization or aggregation of everybody together and then disbursement as is needed, right? A lot of people wonder what insurance really is. This is the best explanation I can come up with or I've heard. Insurance takes the probabilistic nature of the world and turns it into a deterministic outcome. Meaning, you have a 0.0% chance of having a heart attack, and that heart attack is going to cost you $500,000. All right, broad strokes here for the ease of math. Well, you realize that you can't cover a $500,000 bill. That's just not going to happen. But you also realize that you can pay $3 a month, and that heart attack is now covered. That is taking the probabilistic, which is very low, that 0.0%, and turning it into deterministic. I just pay $3 and it's taken care of. Now we aggregate all of those things together, and that's where we come up with the risk factors or the cost of the insurance. But because we have that trade-off that the AMA made back in the Truman administration of fee for service, we need to know what exactly is being paid for, right? They're being paid for what they deliver. Well, what are they delivering? Tom, you can say that you're paying for what they deliver, but how do we categorize that across an entire country of hundreds of millions of people? Well, that's what we came up with on the fee for service and the indemnity model, right? So the first thing that they did is they came up with a model where they could identify the delivery of each portion or each part of care. After that, what they ended up doing was saying, all right, we've got these units of consumption of care, and we've identified these inside of our policies. They are all covered. They're all the probabilistic that have become deterministic. We're going to cut the doctors or the providers or the hospitals a check for those procedures. That was the first level solution, right? Kind of beautiful, kind of simplistic, but it worked. But eventually, like all third-party payer problems or third-party payer models, a problem develops, right? Now, I know he's mildly controversial, but a man by the name of Milton Friedman, who won the Nobel Prize out of Chicago, came up with a system of identifying different value drivers inside of consumption in general, all right? He said a couple of things, and he got the Nobel Prize for this. One, People spend their money on themselves the most frugally, or he used the term, economic term, efficiently. People spend their money on others less efficiently than they do on themselves. People spend other people's money on themselves less efficiently than the other two. And the final category is people spend other people's money on other people the least efficiently, right? He proved these things mathematically. The problem that we have inside of our current model is not a problem that's solvable, but it is a problem that's addressable. Those are two separate things. There's no perfection here. There's no utopia. There's only trade-offs. So we have this third-party payer, right? Remember, first, second, third. It's less efficient than the first two. So inherently, it will be more costly to do this model than it is for the person doing it for themselves. But the person themselves cannot make all of these low probability of events into deterministic events. So we have human nature mixed with human nature, which becomes our model. So applying this to indemnity, what happens when you see these third-party payers, right? You realize there's less checks and balances on the consumption and delivery of care inside of this model than there is on somebody going to the doctor themselves. If the doctor says, I saw you for 3 hours, and you were there, and you say, no, you didn't, you were there for 10 minutes, you're not gonna pay that, and you're gonna be upset with the doctor. But when you go to a hospital system now, and they don't know how long he was in there, the hospital themselves will start, arguably there is human nature that kicks in here, to start changing what they actually bill. And so what you saw as the system developed and matured, you saw the development of aggressive billing practices. You saw the Wall Street effect, in my opinion, where large conglomerates will come in and buy hospital systems and change the billing practices, right? And from their mind, it's we're only defending what we need because the insurance companies are big and evil. We need to do it in this aggressive way, right? And so you go down this model where the insurance companies are the aggregators of all that probabilistic are the evil ones, and the hospital providers are the noble ones. Well, no. One's probabilistic, one's deterministic, but you're still lying to me, or you're still lying to the insurance industry. So what happened after that was the development of a piece called an HMO. Now, you guys are probably all familiar with an HMO. It's a health maintenance organization. And what it tried to do was flip back at that original trade-off, right? This is in a brand new category of fee-for-service versus health maintenance, right? And it makes something beautiful to begin with. And it worked really well off the start. People went in there, they saw that they were getting actual time with their doctors, right? Because they were there themselves and they were identifying on it. They were paying for fee-for-service, or fee for maintenance, so they're better incentivized to keep the patients healthy rather than keep them treatable. And there's a massive difference between those two. So as the HMOs pop up, they're addressing that principal issue, which is the difference between fee for service and fee for maintenance, all right? It works beautifully for a while, but what happens? Well, that same part of human nature that we can't get rid of, that same Wall Street idea or Wall Street effect kicks in. And what they end up doing is they stretch out the wait times. They stretch out the pre-certification process. They make everything more difficult to consume. And at first, it works pretty well. And then people get really upset. So they were able to change the model, then make the hospitals very, very profitable, make the HMOs and the Wall Street effect, the Wall Street types, come in and they start sucking nickels out of the system. And when you suck too many nickels out of it, people start to rebel and new models come up. So that brings us to probably the most common today of the pricing models, right? So remember, we had FDR, who did the Wage and Price Control Act. We had Truman and the AMA negotiate, and it landed on the fee-for-service model. We had indemnity rise and fall due to the third-party payer problem. We had the HMO rise and now begin to fall. There's still some indemnity plans out there, let me be clear. There also is still some HMOs out there, to be clear. And those tend to be the ethical ones, right? The next model that pops up as the HMOs are becoming Wall Street affected, Wall Streetified, right? There's a model called PPO. Now, PPO seeks to bridge those two things together, and it does it pretty well for a while. But we're going to cover that in the next video. Again, my name's Stein Jr. We are American Trust Administrators. This is the history of level funding, how we got from FDR and how we're going into the future. If you have questions about ATA or about level funding in general, please reach out. We're here to help. We enjoy what we do, and we have a decent amount of information. If you have a great question, I don't know the answer to it, thank you. So make me say thank you to you. We'll see you out there. Bye-bye.